Welcome to the Compounding Center Connections, where we talk about different health conditions with our partner practitioners. I'm your host, Jay Gill, a compounding pharmacist from the Compounding Center in Leesburg, Virginia. At the Compounding Center, we collaborate with practitioners, create custom medications to help our patients get better. So in this episode, we have a returning guest, Dr. Kevin Chan, the Senior Clinical Director at Treehouse Eyes in Tyson's Corner, Virginia. So in this episode, we're going to focus on talking about low-dose atropine eye drops and why does it have to be compounded. Now, in our earlier podcast, Dr. Chan talked to us about childhood myopia, and in this one, we wanted to focus a little bit more about the treatment and use of low-dose atropine eye drops. So Dr. Chang, thanks for joining us. Before we get started, could you please introduce yourself to the viewers and listeners?
Sure. Thanks, Dr. Gill, for having me on this podcast. My name is Dr. Kevin Chan. I am the Senior Clinical Director at Treehouse Eyes in Tyson's Corner, Virginia. So for those who are not familiar with Treehouse Eyes, we are the myopia dedicated clinic, which only exclusively provide myopia management service for young kids. So we only serve pediatric population, and essentially myopia occurs. Essentially, it's also known as nearsightedness, and it occurs when patients' eyeball become too long. They're elongating more than they should. So therefore, they will experience the symptoms of blurry vision. So the way we treat them is by using different treatment modality, including something called orthokeratology lenses, which is a type of rigid contact lenses whereby we can correct the vision during nighttime so that they can sleep with the lenses. By the time they wake up in the morning, vision will be well corrected. The second type of modality is the soft multifocal contact lenses for daytime use. And then the third, but not least, is the topical atropine medication, which is the primary interest of the podcast today.
So everyone, the information discussed today is for informational purposes only, not for diagnosis. And so let's get started. Dr. Chan, just take a few minutes and talk to us about what is myopia, what is happening to the eye, and perhaps some common symptoms that a parent should look out for before we dive into low-dose atropine eye drops.
Sure. So as I alluded earlier, myopia is a medical eye condition, also known as nearsightedness. So it occurs when our eyeball becomes too long or elongating to what it exceeded to what is a typical expected level. So typically children, especially children, would experience a lot of symptoms associated with myopia, including blurry vision without correction, or they may have a habit of rubbing the eyes, or squinting in school, not able to see well, having a lot of eye strain, or even headache after school. So there, as I said, there are a number of treatments that can be available and suitable for young kids. We'll dive into a little bit more in detail.
Talk to us about like how important or critical is it to diagnose this earlier in life, and and to keep up with those scheduled visits so we delay some downstream adults. We may have higher probability against certain conditions. Could you touch upon that a little bit?
Sure. So statistically, we're seeing that back in the 1970s, there are only about 25% of the population being diagnosed with myopia. Fast forward 3 decades later, we're also seeing nearly 66% increase of the prevalence of myopia. So these days we are seeing, tons of kids having myopia, and it's also projected to rise to a different level. By the year of 2050, nearly half of the global population will become myopic. So essentially 1 out of 2 kids would need to have glasses or having some sort of visual impairment. So that is a really critical message for parents out there who are not yet familiar with the idea of myopia. on how to provide the best eye care service for your kid. So that's why it's really critical important to make a diagnosis early so that the kid can be well treated, because myopia actually have a specific window for which we need to treat properly. If we miss the window, then kids will be more likely to progress over time. And then the delayed treatment will also somewhat affect the clinical outcome at the end. So it's really important to bring the kids to the eye exam, as young as 6 months old. And then by the time we're able to diagnose them with myopia, there are many, many different idea and options we can provide for slowing down their myopia so that the rate of visual impairment will be much reduced.
Okay. So one of the treatments option you mentioned you use is low-dose atropine eye drops. Could you tell us how does it work and how effective it is for this condition?
Yes. So typically atropine drops has been studied in the past 2 to 3 decades. And although the actual mechanism remain unknown and need more research to substantiate it, but what we found based on the number of theory is that atropine drop work by upregulating the one of the neurotransmitter cell called the dopamine inside the retina. And then when the dopamine cells is being upregulated or stimulated, they can actually help the eye to shape the way so that it won't continue to elongate. Another type of theory suggests that, because atropine drop itself have dilated features, meaning the pupil will be slightly enlarged after the instillation of atropine. So some theories suggest that by using a dilating drop, it will actually help the light enters the eye much easier, and that sort of light entering will actually help stimulate the eye in a different fashion so that your eye will be less likely to progress over time.
So let me give some insight onto our listeners and viewers on why low-dose atropine has to be compounded. Now, we define low dose atropine as anywhere in the range of 0.01% to perhaps 0.1%. It is available at a regular concentration at 1% from a retail pharmacy. It's manufactured, and you can get it at a regular retail pharmacy at a 1% concentration, and it's a sterile eye drop. So low-dose atropine has to be basically compounded by a compounded pharmacist. And we at the compounding center are certified and equipped to make sterile formulations. And sterile formulations basically require a totally separate environment or a different suite that is, for simplicity's sake, it's a very clean environment, a clean environment where your equipment and the personnel is garbed up head to toe, gloves on, and you are using technique that ensures there's no risk of contamination to the product that could lead to an infection. So, most of us compounders, and we particularly at the compounding center, we take the 1% atropine eye drop and we dilute it down by 100-fold by, adding normal saline to it down to a 0.01%. And that's the low dose atropine formulation. Now, the starting product, which is atropine 1%, is sterile, and we dilute it down with a sterile normal saline. So it's a very low risk sterile compounded preparation that's considered in our industry because we're combining two sterile products. Now, one of the things that I want the parents and even practitioners to know is when you get the manufactured atropine 1%, it has a preservative in it, and it's called benzalkonium chloride, which is there in a certain amount, and its properties are that it's a preservative. and it helps preserve that formulation so no bacteria or microbes grow in it. That's its purpose. So imagine now we have taken as a compounder and diluted this down by 100-fold. Now we have diluted this preserved benzalkonium, this preservative benzalkonium chloride by 100-fold, therefore making it negligible and, almost eliminating its properties that it's there for as a preservative. So it is an ineffective preservative at this point. So, the unique thing that we do at the compounding center is we actually then take this diluted low dose atropine and package it into a bottle that is designed for preservative-free eye drops. And this particular bottle is, I'm sure you're used to seeing this, Dr. Chan, but it might look different to some, to others, because we're more used to seeing bottles like this, when we buy things off the shelf. So bottles, this type of bottle delivers one drop at a time. So it's what they call a closed container. So when you squeeze out one drop, it does not allow any air to go back into the product itself. So it's a closed container. So we have no preservative or very negligible amount of preservative, and there's no air going into the product. So the probability of this product remaining sterile is much better than something that is packaged in this type of a bottle, which is open. So once you open it, the product is not sterile anymore, and the parent might be using this for up to 3 months, perhaps, the product that's in it. So, the reason it has to be compounded and packaged in an appropriate bottle is very important here, and recognizing that it's practically preservative free. So that's one of the things that we get a lot of questions on is, why does it need to be compounded? And the other one is me ensuring or giving the confidence as you, the practitioner who is prescribing this medication, me, the pharmacist, making sure this product remains sterile throughout its use by using an appropriate container, and obviously the confidence of the parent, because it's kids' eyes that we're talking about here. So one of the other things, before I forget, I want to touch upon is we've had our product tested. In fact, we've had this particular bottle tested that it does not leak any air into it. We've had the product tested that it remains sterile in an unopened bottle for up to 180 days. We've also had the product tested that the product is potent for 180 days. And the way we dispense it at the pharmacy is we literally dispense 3 different bottles to the parent. So each bottle is to be opened and used for up to 28 days. And the parent, once they open it, it's stored at room temperature. But once they open it, we want to take an extra level of safety. And we usually ask them to, keep it in the refrigerator, but it does not have to be stored in the refrigerator. And lastly, when we don't know where the product, once it's dispensed from the pharmacy, is going to be stored, whether the parent is traveling with the kids or it's stored in a bathroom, these are environments that we can't control. And it makes you wonder, why would we dispense it in a bottle that's open, in an open container? So that is something that I wanted to share with our listeners and viewers about. And I'll make sure I will put, especially for our viewers, our listeners, in the show notes, the picture of this unit dose bottle. I know you had a question regarding that you get quite often about using multiple drops or a concentrated drop. And did you want to go ahead and what's that? Go ahead and ask that.
Sure, Dr. Gill. So I encounter a lot of questions, especially this is a top number one question from both practitioner and also parent. They were wondering, if there's any differences in terms of the clinical efficacy between, especially for atropine drug when they're low dose concentration. We'll typically start with the 0.05% with one drop, but depends on the patient's risk factor and how the treatment progress goes. Sometimes we have to specifically cater for each individual. So we may have to alter the number of drops being used. So from one drop up to increase to 2 drops per night. Question is, what is your comment about the clinical efficacy between using 2 drops of 0.05% atropine versus 1 drop of 0.1% atropine?
So, Dr. Chan, from the pharmaceutical perspective, the amount of dose of atropine or the drug that you're getting, whether you use 2 drops of 0.05 and 1 drop of 0.1, is the same. I think it is more very patient specific because of the tolerability of the child. What I mean by that is sometimes when you make a concentrated drop such as 0.1, even though it's 1 drop, it might be irritating to the person's eye. So for that patient, you may have to use a different strategy and use 2 drops of the 0.05 and see if they tolerate that better. Okay. On the flip side, you can have a patient that, on the 0.05 is basically, too much for the kid, that you needed something concentrated for them and they're able to tolerate it. It's very patient specific. But for efficacy standpoint, both scenarios works well and they get absorbed.
That's great. It's a great reassurance for both practitioner and also the parents, so that they don't have to freak out, when they're running low of medication.
And I would say, it's our conversation that we have with the parent. If the 0.1 is too irritating, doesn't mean the therapy has to be changed entirely. We need to drop down to something weaker and use multiple drops, 2 drops. Or on the flip side, if the child is not able to stand still to have 2 drops put in both eyes, perhaps we can try the 0.1% and see if that works for that particular child.
Great. I see.
So, one of the things I'm always, trying to bring to attention because of today's environment and technology is, could you share with us some of your recommendations and that you talk to the parents about, some perhaps unhealthy habits that kids may have that we need to kind of talk to them about, and what your recommendations would be to change these habits just to delay the progress of this condition.
Right. That's a great question. I encountered, this question almost every single day from parents. They were, wondering and also pretty concerned about the amount of screen time that their kids are using. And especially, during and since the pandemic, more and more classes are switched from in-person to virtual, even though the situation is now getting a little bit more relief. But still, the kids and adolescents are spending exorbitant amount of time of screen time. And pretty much everything is done on this computer and tablet. So it's not the most healthiest habit for them to engage in. So I strongly recommend parents to bring their kids outside at least 90 minutes a day, if possible, so that it would help them have a lot more outdoor exposure. The reason is some study have found that sunlight, the natural outdoor exposure, can actually help mitigate the progression of myopia. So kids are less likely to grow as fast as someone who are in indoor. Number of study, done in different continent between, like, for example, Singapore and Australia. The kids that are growing up in Australia are actually less likely or less prone to the progression of myopia, mainly because their classroom and outdoor time are much more flexible than those kids are being studied in Singapore. Those are the environment that has been so confined. They're being indoor all the time. So the take-home message for parents is that you do have to spend a bit more time with your kids outside and try to regulate the amount of screen time that they're doing.
Well, thank you very much for sharing those recommendations. And I thank you for joining us again and asking us to clarify as compounders how it's compounded. Now, if someone wanted to reach out to you, how can they reach out to you?
Sure. So feel free to contact me. My email address is Kevin, Kevin, Chan, Chan, at treehousesize.com. So same question for you, Dr. Gill. How would parent be able to find you and your pharmacy get more information about atropine drops?
Well, we can be reached, by you can look us up on Google, the compoundingcenter.com, and you can either text us or call us at the number listed, and it's 703-779-3301. And I'll make sure that we put both our contact information in the show notes, so everybody can have that. And everyone, thank you for tuning into the Compounding Center Connections podcast. We hope you found this information presented to you be helpful. If you have any comments or questions, please feel free to reach out to me at j@compoundingcenter.com. Subscribe to our YouTube channel and our podcast channel, The Compounding Center Connections, and stay tuned for future episodes.
Thank you.